Well, good afternoon, everyone, and welcome to this semester's first Islands Matter seminar, where we explore interesting research that's being undertaken across the Scottish Islands and further afield as well. But today we're definitely fixed in one of the Scottish archipelagos, although maybe some Shetlanders would argue against that. And we're going to explore with Lynn Anderson, who's undertaking a PhD with the Institute for Northern Studies. We're going to explore the impact of islandness on health services in Shetland between 1908 and 1948, when the National Health Service began. Lynn has been doing some really interesting research on this subject. I'm one of her supervisors, and I've enjoyed working with her, and she's been very diligent in exploring all sorts of detailed minutes from county councils and all sorts of things, and doing what the AI research tells us is a deep dive into the materials. So she's going to explore that with us today, and once she's finished, we'll have the opportunity to ask her questions as well. So the Q&A session thing should work. So if you click on that button at the top, if you have questions for Lynn. So without further ado, let's begin. Hello, Lynn. It's great to see you.
Hi, Andrew. Thank you very much for that introduction and for inviting me to present my research here today. As you say, my research is about health services in the first half of the 20th century, before there was an NHS, and I'm interested in how Shetland, as a remote island, managed these. I'll just share my screen.
That's it.
Excellent. Is that okay? Can everybody see that?
Yep, looks good.
Okay. So as I said, it's about the impact of islandness on health services in Shetland in the first half of the 20th century. As you said, Andrew, my sources, I've been in the archive for, it feels like months and months. My resources are minutes of meetings of the local authority, the medical officer of health reports, annual reports from the central authorities, and newspaper reports. And I've pieced together events around these health schemes within this time frame. So I'm probably about 2/3 of the way through the project. I don't have conclusive findings, but I'll present to you the work that I've done so far and the themes that I feel that are emerging. But just before that, Shetland, just to let you know, for anyone who doesn't know where Shetland is, we're north of the UK mainland, in red there, Norway to the east, and we've got Faroe to the northwest. And you can see Edinburgh marked there at the bottom of the map. That's where the central authorities that were responsible for the health schemes and various other local authority business were based. And as you can see, we're not in the usual box that you see us and sometimes on the maps on the television. So just to give you some background first, local authorities were at the forefront of providing health services, or the government-led health services at the time. And it started with the Poor Law in 1845, whereby paupers were entitled to receive medical care. Then the Lunacy Act was passed in 1857. People with mental health conditions were to be managed under medical supervision. And this often asylum care was believed to be the best option for people. are the most appropriate option. But of course, we didn't have an asylum in Shetland, and this meant sending people away to the mainland. Sometimes they never came back. And then in 1867 and 1897, there was public health legislation introduced, a whole raft of measures, environmental services such as sanitation, housing, factories, acts, dairies, bakeries, workshops, slaughterhouses. These all had to be managed and regulated. The other part of the Act dealt with infectious diseases, specified diseases that were notifiable, such as smallpox and cholera. These had to be managed by local authorities. And local authorities had to appoint a medical officer of health and a sanitary inspector. And they also had to provide an infectious disease hospital, commonly known as fever hospitals in the past. And all this legislation was compulsory. There was some grant aid available, but they had to raise funds from the rates in addition to pay for these services. Then coming into the 20th century, government was concerned about the health of the population. These other services were quite well established, but then there was a whole host of new concerns for the government. There was a high infant mortality rate. That's the number of children who die in the first year of life per 1,000 live births. And there was a fall in the birth rate. And the health of recruits for the Boer War was seen as quite abysmal. Between 25 and 60% of men presenting at recruiting centres were found to be unfit. And this was a worry, given that Britain needed a healthy population, fit to work and help the country be economically productive, but also fit to fight should there be any conflict, which of course there was. There had been inquiries and reports commissioned which demonstrated links between poverty, housing and health, Rowntree and Booth, for example. And there had been a tendency to equate poverty with laziness. But social reformers, these ideas were changing, and there was a realisation that people were poor because they weren't well enough paid and weren't enough jobs. And they were caught in a cycle of deprivation, and something needed to be done. So a Liberal government was elected in 1906, and they brought in a whole host of health and welfare reforms. For example, old age pensions, national insurance for unemployment and sickness, labour exchanges to help people find work, and a range of health schemes which have been termed personal health services. That term was coined during the Second World War, and I think it was used to sort of distinguish between those schemes that were environmental or public health. And it's the term that's been used in research since. So it's these personal health services that I am interested in. And the ones I've been specifically looking at are school medical inspection, mother and child welfare, tuberculosis management, and venereal disease treatment. There were some other health schemes, but they were much smaller in scale. These were the four that were the biggest challenge for local authorities, and they also seem to occupy the most attention in the government annual reports. It was considered that by looking at the health of children as they moved through the school system, issues could be picked up and children would enter adulthood in better health, ready to take up useful work. Similarly, if women had healthier pregnancies, safer deliveries, and if infants and young children were better nourished and grew up in a healthy environment, then this would give them the very best start in life. In the case of tuberculosis and venereal diseases, both of these were infectious diseases which were widespread at the beginning of the 20th century, and both were singled out for special measures. So I'll go through each of these, and I'll speak a little bit more about the challenges of setting up the services here in Shetland. Some of the key themes that I've picked up that from my work so far are to do with, some of them are to do with the scheme specific. Some issues are to do with the resources, both financial and staffing. There are geographical factors that have impacted, there's inequities, and there's some external factors that affect the schemes as well. But I'll come back to these at the end. And just for anyone who maybe doesn't know Shetland, this is a map of Shetland here. There's one main island and around 100 smaller islands. They're not all inhabited, these other islands. Some are just a short boat crossing. Some of them are more remote, like Foula and Fair Isle there. The population of Shetland in the early 20th century was around 28,000. Around 5,000 lived in Lerwick, the main town there on the east coast of the mainland. The main industry was fishing at this time. Men also sailed. People lived in the rural areas, lived in small crofts, which provided some of the basics of everyday life. Women managed the crofts when men were away, and they knitted to eke out the family income. Shetland had moved from a subsistence lifestyle, but generally folk weren't very well off. Okay, so turning to the schemes themselves, just start with school medical inspection. So this legislation was introduced in 1908 with the Education Act. Initially this was permissive, but by 1910 the local authorities were being told that this was compulsory. But 50% of the local authorities' costs would be reimbursed. Shetland doctors thought this was a good idea. The local authority didn't seem to be quite so sure, but they all argued that it was too expensive and they didn't know how they could introduce this. It would mean increasing the rates, and Shetland was a poor place. People couldn't stand an increase in rates. And Shetland's local authority would only introduce this if they got 100% grant aid to cover the full cost. And this was debated for a few years, and then it was delayed by World War I. And Shetland was actually the only county, along with Orkney, who had not introduced school medical inspection by the end of the First World War. But soon after, they got going and they appointed a doctor to carry out school medical inspection. You might ask, why didn't they just use the local doctors, the local parish doctors? They would have been more expensive, but also this work had to be done by somebody who had a diploma in public health, which the parish doctors probably didn't have. So it needed to be a new appointment. But they got the best, they got their money's worth, because they appointed the doctor. He would also be the TB officer. He would be the medical officer of health for the county, and he would be the medical officer of health for Lerwick, the main town. So he had a busy role. He set up the school medical service from scratch. And there were 63 schools across Shetland. He found the role quite challenging. The remoteness of many of the schools, it was difficult. Some involved boat crossings. There weren't roads to every area. The weather, the shortness of the day, all these brought difficulties. But it was doable, and it was done. So, and he also set up a school health clinic in Lerwick. But in the rural areas, any follow-up depended on there being a nurse in the parish, which at that time there wasn't. There was nothing really remarkable about the health of the Shetland children that was different from the mainland. In fact, successive medical officers found that Shetland children were above average in height and weight. But of course, within that cohort, there were children who were poorer, poorly nourished, and had medical conditions. The main issues that were found with children were personal hygiene, nits in the hair, vermin on the body, and dental health. And this was the same issues across Scotland, particularly with dental health. Many areas had introduced a dental service, but again, Shetland were very reluctant to do this. They cited financial reasons. They couldn't afford to employ a dentist. They couldn't increase the rates to employ a dentist. And this was consistently raised throughout the years with the central authorities. And eventually in 1939, they did employ a dentist, and he went around all the schools with a caravan and did the necessary pulling of the teeth, etc. But again, there had been a delay in setting up what was really an essential service. Turning now to mother and child welfare. This legislation was passed in 1915 in conjunction with the Notification of Births Act. But while notification of births was compulsory, the mother and child welfare element was permissive. The local authority could, if they wished, introduce a scheme to support women in pregnancy, during birth, and for infants and children up to the age of 5. But there was no specific requirement that had to be met. Local authorities could claim 50% of costs incurred, but schemes had to be authorised by the central authority. Also in 1915, the Midwives Act was passed, and this required regulation and certification of midwives. And it was intended to stop the practice of local women who were often called howdies or handy women from being involved in childbirth. These howdies could be fined if they were caught practicing midwifery without being certified. Of course, there was only one midwife in Shetland at that time, and she was in Lerwick. Local authorities here thought that mother and child welfare wasn't really necessary. They thought children were well looked after and there was no neglect. But of course, there were cases of hardship. They couldn't see how the Midwives Act could be introduced either. But the new medical officer was keen to get the scheme in place. So along with school medical inspection, he set up a child welfare clinic in Lerwick. But this type of thing couldn't work in the rural areas, even if centres could have been set up in the rural areas. Pregnant women, women with babies and young children, they couldn't travel. The rural areas were too spread out, the distances were too great, roads were rudimentary or non-existent, and transport was limited. So, and again, this wasn't the type of scheme that a local doctor would deliver. Their fees would have been far too high. They would have charged the local authority to visit each woman. But they did attend women in childbirth if they were called in an emergency. The solution really was that every parish needed to have a nurse who would visit women and children at home and fulfil both these pieces of legislation. But for a parish to have a nurse, they had to form a nursing association, and each family had to pay 2 shillings 6pence a year to that nursing association. They could then apply to the Queen's Jubilee Nursing Association for a nurse. And this seemed to be a bit of a sticking point. Some parishes paid for a nurse, but others didn't agree. But until there was a nurse in every parish, the local authority wouldn't instigate a Shetland-wide scheme. There was further legislation in 1927, and that perhaps focused the local authorities a bit more and the parish councils to do something. The provision of a midwife was made compulsory by the government, with the local authority responsible to do that. And also the fine was increased, the amount that local women would be charged if they were caught dealing with childbirth was increased. So, this perhaps, as I said, focused the minds. Eventually, by the beginning of the 1930s, every parish did have a nurse, and a full mother and child welfare scheme was put in place in 1933. There was a district nurse in each of the rural areas, and they would attend women during pregnancy, attend births, and provide postnatal care and infant care. They may not have been fully qualified midwives, though, but they would have had some maternity training, which allowed them to attend women in childbirth. And if they had difficulty, then they would have called in a doctor for the birth. There was then more legislation in 1937, which required women having home births not only to have the services of a midwife, but also a doctor and access to an obstetrician. But this legislation was held up by the Second World War across the whole of Scotland. And then, of course, the NHS Act was passed. So I'm not going to really go into any of that. It's another long saga. But Shetland eventually had a maternity facility in 1947. Up until then, most children were born at home, as probably across much of the rural areas and remote areas, and indeed much of Scotland. So just turning now to tuberculosis. This was a serious infectious condition. The rates were very high in Shetland. The rates of tuberculosis was high across the whole of the UK, but across Shetland and the Western Isles, it was particularly high. And possibly being an island community maybe impacted on this. There was a lack of immunity within the population, but the lifestyle, people living in small croft houses, generally overcrowded, and also in the town, the accommodation was very overcrowded. And this gave the right conditions for infection to spread. And Shetland, along with the Western Isles, had the highest rates of TB in Scotland. The government did pass, along with the National Insurance Act, the sanatoria benefit was included in that. But this was only for insured people who had TB. But soon after, within a year, TB was made a notifiable disease, which meant that it was compulsory then for local authorities to provide treatment. Local authorities would be reimbursed for 50% of the cost of TB treatment. Of course, when I speak about treatment, there was no cure for TB, and treatment just consisted really of fresh air, rest, nourishing food, and isolation. And isolation was crucial to prevent the spread of TB. And care within sanatoria was seen as the gold standard treatment. But of course, Shetland didn't have a sanatorium. Other areas were providing, making arrangements to provide sanatoriums, and there were capital grants available. But Shetland had a bit of a piecemeal arrangement. People were managed at home, but this wasn't really isolation within these small croft houses and being overcrowded. They used a wing of the fever hospital, which had 8 beds, but if there was an epidemic of some other infectious disease, such as scarlet fever, which did happen, then the TB patients were turfed out and sent home, and which of course put their families at risk again. People were sent south to the mainland for sanatoria care. These were insured people, and others tended to be younger people to give them the best chance of recovery. And also wooden shelters were used, and you can see one in the image here alongside the little croft house there. This was commonly used around Shetland. They weren't very robust. They let in the rain, they blew around, and in stormy weather, sometimes people had to be rescued out of them. And really, they were described as glorified hen houses. Not a very pleasant existence, really, for people with TB. Those people who were getting care at home and people in shelters, they got an allowance from the local authority, and this was for nourishing foods and comforts. And this was the situation for a number of years, all the while the local authority were being pressed by Edinburgh. What were they doing about TB, and what were they doing about providing a sanatorium? But the local authority said here it was too costly, there was no money for a big project, and it was the usual mantra, they couldn't increase the rates because people couldn't afford to pay the additional amount that was needed. So you can see from this graph that the rates of TB escalated. The graph is actually really a bit misleading because the graph was started in 1920 when the TB officer was appointed, who was also doing schools and mother and child welfare. He set up the register. But people were very reluctant to come forward they didn't want to be diagnosed with TB, and there was a secrecy around it. And I think the figures would have been much higher in the early 1920s. The blue line there is the number of cases at the end of each year on the TB officer's books, and the green line is the number of deaths from TB. The number of deaths seem to be quite stable, but as you can see, the cases increase and then they start to fall away. The local authority also appointed a nurse in 1920 to deal with tuberculosis. She also dealt with school medical inspection and child welfare, but she was only appointed for Lerwick. And so again, the rural areas were reliant on there being a nurse in the parish if available. And as I've just said, this didn't happen until the end of the 1920s, beginning of the 1930s, was there a nurse in every parish. So the TB figures increased throughout the 1920s, and Edinburgh was still pushing Shetland to provide a sanatorium, but there was financial difficulties. The local authority had an overdraft, and in fact, with the financial crash in the beginning of the 1920s, many local authorities were in the same boat. And Shetland's local authority was having to get a loan to make ends meet. So there was no way that they could afford to build a sanatorium. They did try various options. They considered extending the existing hospital. They considered converting some wooden buildings at the hospital. There was the offer of army huts. There was also the possibility of converting one of the large mansion houses in Lerwick. And of course, there was the option of the new build. But all were expensive, either too expensive or they weren't approved by the central authorities. What the central authority did do was increase Shetland's allowance, the amount that they could claim. So from 50%, they increased it up to 66%. So Shetland could claim 2/3 of any costs of tuberculosis. The Western Isles, or some of the Western Isles, actually got 80%. So their situation was even worse than Shetland's. There was a number of education campaigns that took place throughout the 20s, spearheaded by the medical officer to try to reduce numbers. Eventually, the Scottish Board of Health took pity on Shetland and they agreed a special Highlands and Islands Medical Service grant to allow them to build a sanatorium. Of course, that money had to be paid back eventually. So Shetland got on with it. They purchased a plot of land, and building began, and Montfield Sanatorium was opened in 1928. And that's Montfield there, and you can perhaps see there's beds out there on the veranda, people getting their fresh air. The sanatorium didn't, of course, all of a sudden deal with the issue of TB. It wasn't the panacea. The sanatorium was immediately filled up. People were still being sent south, shelters were still being used, and people were still being managed at home. It was one of these things Shetland didn't, with epidemics. It just ran its course, and the figures began to fall eventually throughout the 1930s. So that by the time of the Second World War, it was said to be endemic. There was better immunity. The education campaigns had probably helped, and housing was improving. But there had been a huge financial cost. It was the biggest cost to the local authority, along with the road building programme. So lastly, venereal diseases. This was another very high rates across the whole of the UK of venereal disease. Of course, it had been prevalent for time immemorial, really. And it was seen not only as a threat to the nation's health, but also not only physically, but also morally. Also, a treatment had been developed, the salvarsan, in 1910, and the government thought that where there was a treatment, it should be provided. So there was a Royal Commission on VD ordered, and it was reported on in 1916, and then legislation was passed. It was seen that treatment centres would be the best option to deal with VD. Unlike TB, which was made a notifiable disease, VD was declared a national emergency, and this allowed the government to compel local authorities to provide free, private and confidential treatment for sufferers. And the local authorities could claim 75% of their costs incurred in any health scheme. Initially, Shetland denied that there was a problem in their area, but of course, every area had a problem. Shetland had an influx of workers in the summer for the herring fishery, and also regular maritime traffic coming in and out of the island. So the local authority got their heads together and they got on with providing a treatment centre. Premises were found in Lerwick. All that was needed was a clinic room, and this was well within the council's means to provide. Local doctors could already in practice could provide the treatment. It didn't need a specialist. All they needed was some training. So the whole thing got underway in 1923. It proved to be lucrative work because doctors could claim 3 shillings 6pence per patient per consultation. And soon after the centre was up and running, more doctors wanted to be involved. So it was worth their while to get in on this treatment. It was much easier service than any of the others to set up. And in fact, Shetland had its scheme in place ahead of many other areas, such as Leith, Peterhead, Fraserburgh, Inverness, and all down the west coast. So the nature of islandness was perhaps a push factor in this case, and a positive. So 4 very different schemes that had different requirements and presented different challenges. Where the scheme was permissive, the local authority perhaps dragged their heels a bit. Where it was compulsory, they had to get on and they had to do something that may have had to be adapted to fit the island setup, but something was done. Financial issues were undoubtedly the biggest problem for the local authority. Where there was a project that needed a big capital funding, they just couldn't provide that. They didn't have the funds to provide that. And they were reluctant to increase the rates in order to provide services, although they did have to increase the rates eventually. Something like VD only needed the clinic room. As I said, that was well within the council means. It didn't need that big injection of finance. With staffing, a school medical inspection, it was 1 doctor that was needed. And he would visit all the schools. So that was 1 appointment, and they scored because they also made him tuberculosis officer, and he had the other roles of the county and Lerwick medical officers. With child welfare, a nurse was needed in every parish, and that was challenging. There's probably also a financial element in that some parishes didn't want to have a nurse appointed. I didn't want to spend that money. It doesn't sound very much, 2 and 6 a year for a nurse, but I don't know, probably a bit more research needed there. Again, with VD, local doctors could provide the treatment, so there didn't need to be an additional appointment for that. Geographical challenges. Well, it was certainly challenging for the medical officer to get around all the schools, distance, travel, weather, etc. But also the work of the nurses in the parishes was challenging. Travel was difficult. Roads were very rudimentary, and transport was limited. There was quite a high turnover of nurses, and possibly the geographical challenges were a factor there. Probably the nature of islandness contributed to the high rates of TB, and in terms of inequities, Lerwick certainly had services well ahead of better services than the rural areas. They had the school health clinic, they had the child welfare clinic, they had the midwife, they had nurses, they had the doctors, and the rural areas, eventually they had parish doctors, and eventually they got a nurse. Some of the remotest schools didn't get visited every year by the school medical doctor, so there was a bit of inequity there. And external factors, well, World War I, there was 2 world wars within my time frame, and they both held up some of these schemes. And also there was a financial crash in the early 20s, which caused problems for not only our local authority, but central authorities as well. They delayed some of the schemes, and they delayed some of the capital funding that they were providing. I don't think Shetland's any different from any other island community or remote mainland area. Similar challenges would have been there for other areas. And some of these issues are actually still present today. It's still difficult to get staff in Shetland for doctors and nurses. We use a lot of locums and agency workers still. I think that's all I have to say. So just say thank you for listening, and any questions.
Thank you very much indeed, Lynn. So that you can, well, actually, I can take control and just stop sharing. I think let's just stop sharing. There we go. So we can see you on the screen. Yes. Okay. As always, fascinating, and we have some questions in the chat. I'll just open Q&A as well, see if there's any questions there as well. None there yet, but we have some in the chat. So, yeah. But before I since I'm chairing this, I get to ask the first question. Just before, you didn't say that you also carried out interviews that are just of people's memories of this period before the National Health Service was established. And I just wondered, I know it's not going into your thesis, but I was wondering if there's any stories that particularly stick in your mind from your interviews. You don't have to mention names or anything, but anything that particularly sticks in your mind about how people perceived this period before, and or made use of any of these services that were provided.
Well, the people that I interviewed were children at the time, and they don't have memories particularly of any of these schemes. I mean, what they spoke about a lot was life on the croft, how hard it was, how as children they were roped into working on the croft, getting the water from the well and working in the fields and stuff like this. They spoke a lot about remedies that would be used. Many of them spoke about the cost of the doctor and how the doctor would only be called if it was an absolute emergency. That came across quite clearly that they relied on their own sort of remedies and their own communities to support them, and the doctor was really only called if it was an emergency. They spoke about the nurse having a parish nurse, and that was a service that was very well thought of and appreciated by them. Some of them spoke about when there was an emergency or an accident or something, how difficult it was to get up to Lerwick, where the hospital was, and how sometimes people had to be sent south for care because there wasn't the specialist equipment or whatever here in Shetland.
Yeah, thank you very much. So my follow-on question for this before I direct you to the ones in the chat. People were forced to do things for themselves, the parents of these children. There was an element of self-sufficiency within the community. Do you think that fed into the resistance of bringing in these national schemes in some way? Because people knew how to do it themselves.
I think that the people themselves probably weren't just that aware of the schemes until they actually came in. I don't think they had much say in the matter. I know they were reluctant. Some parishes were reluctant to get a parish nurse. I've not actually really been able to find out much about that. I probably need to go to another set of records, which are the parish council records. I've not actually tackled them, but most of the parishes did eventually have nurses, and where there were nurses, they were really appreciated. Mm-hmm. I don't know. I think with tuberculosis, I think it was there was a fear of tuberculosis, and there was a stigma to tuberculosis, and that was probably a reason. I don't think they were resistant to the tuberculosis services. They were resistant. They didn't want to be labelled as such, I think. Mm-hmm.
Yeah.
With school medical inspection, I think parents were quite happy with school medical inspection. Mm-hmm. They didn't have to actually pay anymore for it, and their children were getting looked at. And of course, if there was an issue found, if the child was found to have some medical condition or surgical, like tonsils or whatever, then they would have had to pay to get that treated. So, but it's very difficult to get stats about medical and surgical figures for treatments as such. So I'm not really sure about how many parents did actually pay to get their children treated.
Yeah.
The local authority paid when the parents didn't have any money. The local authority would foot the bill for that. Yeah.
Thank you very much. Okay, so if we turn to the chat, Eleanor says, as was being a fascinating talk, she was wondering if there was a precedent to get local professionals involved or appointed in the positions. Was there any opposition to perceived outsiders coming in at all? Like local nurses?
Yes, yes, thank you for that question. I think there was. I have come across that, that the local authority would prefer a doctor that was already in post to take on a position. For tuberculosis, they wanted the local doctor that was there for Lerwick to take on the tuberculosis role, but he didn't have a diploma in public health, and they actually sent him to Aberdeen to get the diploma. But he was an older man, and I think he didn't. Something happened. He fell ill when he was in Aberdeen, and he didn't actually succeed in getting his diploma. So in the end, they had to appoint, but they scored because they didn't appoint a doctor into just one role. he was doing the schools, he was doing tuberculosis, and he was the county medical officer. And being that he had all the public health remit was on him. So he was responsible for all these other services, schemes as well as for all whenever there was an outbreak of an infectious disease like scarlet fever, diphtheria, whatever, he was the one that had to deal with that. So it was a huge role. The first one lasted 9 years, I think. And then there was about 4 or 5 others before the National Health Service came in. So, but of course, the Second World War, possibly, that doctor at that time was called up. So, it was a big role.
Certainly sounds like it. Goodness me. Thank you very much. And Maggie and Fiona say the fascinating talk, and they're actually interested in comparing the picture that you've been painting in Shetland with that in Orkney. They've been researching the medical situation between 1894 and 1948, especially the high number of early women doctors who came to work in Orkney. So they'd be interested to know if there was the picture in Shetland was similar, but they'd be happy to discuss that at a later date. So maybe we can get Maggie and Fiona's email, and they can contact you, and you can have a discussion about that. Then moving on. Yeah, that would be good, wouldn't it? Matthew says, you mentioned a few occasions when it was argued that Shetland didn't have a problem or didn't need certain interventions, but was it ever argued that national health legislation and policies were inherently unsuitable for Shetland or in an island context?
Yeah, that's an interesting question as well. Thank you. I haven't mentioned the Highlands and Islands Medical Service. That's a whole huge topic of its own right. But in 1912, 1913, there was a special inquiry into the Highlands and Islands because the medical services were so poor, and the government commissioned an inquiry. And following that inquiry, they set up a fund, £42,000 a year, to support medical service in the Highlands and Islands. So it was basically a pot of money that local authorities could apply for, and which was given to help with the cost of doctors. Doctors who signed up to the Highlands and Islands Medical Service would cap their fee at 5 shillings, and then they would have that topped up from out of this fund. And it also paid for some nurses, not all of the nurses, but it also helped pay for transport, cars, motorbikes, telephones, and all the infrastructure to support health. And I think that central government was aware that the Highlands and Islands was different from cities and from the mainland, and it was a special case. And often in several times with these schemes, they would say that they understood that in the Highlands and Islands that the scheme would have to be adapted in some way, or it wouldn't be able to be introduced in the same way that it was introduced within a big town or a city. They were aware that the things were different in remote and rural areas.
Thank you, Lynn.
Although, the scheme still had to be introduced, but they were cognizant of the fact that rural areas needed a different approach.
Mm-hmm. Okay, thank you. Moving down, there's a few questions, and we don't have a huge amount of time, but let's see. Alistair says he wondered whether Howdies worked much beyond the last legislation you mentioned.
Sorry, what was that?
Did the Howdies continue to work sort of in the background after the legislation that you were talking about, when they had to be registered and things like that?
Yes, they definitely did. the first legislation was 1915, and there weren't midwives in Shetland, and how these were definitely working. But it seemed to be just nobody seemed to raise the issue. I don't know that any were fined actually. There was a sort of a grace period where these Howdies could get themselves registered with the Central Midwives Board, but it was only, I think, 5 years or something. And I suspect that they were definitely Howdies working right through the 20s. But there's no way of knowing who delivered the baby because it's not written down anywhere. You can't tell. There isn't a register.
Mm-hmm.
I mean, nowadays there is, but at that time there wasn't. That type of record wasn't being kept. All that was required was that the child was the birth was notified, and then that the birth was registered. The notification of birth was supposed to happen within 36 hours, but in 1927, out of 180 odd births, only 26 had been notified to the medical officer. So, nobody was chasing up and trying to enforce this legislation. Probably because they realised that they couldn't. It would cost a fortune for the local authority to provide a midwife in every parish. They just didn't have the money to do it, and so it was just sort of, forgotten about, or not forgotten about, but it wasn't really raised. It didn't really feature much in the meetings that were held. It was glossed over.
As many things are. Thank you. John Hunter, he says his late father, Shetland GP Dr. Albert Hunter, recorded some material on early 20th century health for Popper and Dulcish and Radio Shetland. So thank you, John. I'm sure Lynn's aware of that, but if not, that'd be something else to look up.
Yeah, I have. I haven't seen that, but I am aware of it. So yes, I'd be very interested to hear any stories.
Thank you, John. Let's see. Lynn says, did the people trust the medical officers, officials and nurses? What happened to the non-trained midwives? Okay, we mentioned that. Did they get integrated into the system or not?
The non-trained midwives?
Mm-hmm.
You mean, no, there's just no way of knowing that.
We don't know.
I can't find any records that give me lists of midwives and who they were and what their training was. It's just that records are not there. I suspect that the local Howdies didn't go on to become midwives. I think that most parishes then employed a nurse who was sent from the south. There was a very few local women who went away and trained, but I suspect the local Howdies just stopped practicing. They possibly still went and helped women throughout labour, but they would have been calling in the nurse or the doctor for the actual birth. Was there something else in that question?
Well, there was just following up on the Howdy midwifery question. Margaret Ann Sanderson says she finds the mother and child services interesting, and the difference between the early days with home births being the norm and later in your time frame these being less popular. And if she understands right, this was legislated against. She wonders how big an impact this had on infant mortality, this changed a more professionalised system, I suppose.
Well, infant mortality in Shetland was very low compared to the mainland. I think the infant mortality was around, say, 120 per thousand. When Shetland it was like 60 per thousand. So it was round about half in that early in the 1900s and into the early 1920s. it's difficult to say. I think that's a different study. I'm not really looking at epidemiological factors so much. I don't know if any further fall in infant mortality is related to there being midwives or not. It's quite difficult to tease that figures out. And that's possibly a different PhD, to be honest.
Or something for you to follow up after you've finished your PhD. So, because I know you'll be continuing to research this subject, because this is just, you have other materials that you will be using for papers and conference presentations in future. So it's a huge subject with lots of different avenues to be pursued. So I think we'll just wrap it up there. Everyone in the chat seems to have really enjoyed your presentation, and no wonder, it was fascinating. And there's also comments about situations today in some island situations in Uist and in Orkney. So it's it's finding a willing audience. The research that you're undertaking, it's got ramifications beyond just Shetland itself. So thank you very much indeed, Lynn, and thank you everyone for attending this Islands Matter webinar. Keep looking at the Institute for Northern Studies events page, and you'll see some other interesting things coming up soon. So with that, thank you very much indeed. Bye now.
Thank you. Thank you, everyone. Thank you, Andrew.